So if I know that someone has neck pain, or I know that there's an upper cervical dysfunction, so any amount of neck pain or upper cervical dysfunction, I'm going to check the suboccipitals, because so many people are tight here. They live in kind of this OA kind of extended position where their suboccipitals are overactivated, just in general. If I have a headache, someone that has headaches regularly, definitely going to look at suboccipitals. Okay, so someone that has a whiplash injury, almost any cervical, any person with neck pain, we're going to look at this. So how do we assess this? I like to think about suboccipitals in general, not as much specific, like, oh, I'm on rectus capitis posterior minor versus major versus, all the other ones. So I think more, can they move away from the spine, medial to lateral? Okay. Can they move well as they attach onto the occiput, medial to lateral? Okay. And conversely, can they move towards the spine, lateral to medial? And can they move along the occiput, lateral to medial? Okay. So that's the simplest way I know how to describe that, medial to lateral, lateral to medial, and then you're always going to localize with, okay, is it lateral on a diagonal down and away or up and away, or is it just purely straight away? Same thing for lateral to medial, right? Straight towards the spine, down and towards the spine, or up and towards the spine / cranium. Okay, so that's kind of how I think about things. Typically, I will start medial to lateral, where I'm just feeling the spinous processes on the back of the neck. And then I'm just going to spring test away, right, at C2, spring test away at C1, and then check that bony contour along the occiput. Out of those three, I'm most interested in the bony contour at the occiput right now, medial to lateral. And now what are my options for treatment here? I could have her nod her chin down a little bit, even just to try to get her to a little bit of neutral, and let it go. I'll take this moment to insert here. If you have a client who is just hanging out in extension in their natural position, you may want to either put a little blanket or really thin pillow, or try to adjust the head to where they would be in a better overall starting position, and that may give you more true infills for the suboccipitals. So I had to bring the head up for Kelsey a little bit to make her not be living too much into extension. But if I'm working along that occiput, medial to lateral, I could have her nod her head down. Good. And breathe in. Good. And let it go. Okay. Some people that's almost could be too much if they're too tight. So I could have her just look down or look up and see what brings a little bit more tension just with eye movements as the second option. Okay. I could have her go into cover position. So if I'm working on the right side of her neck, I could have her bring her left hand to her right shoulder and nod your chin down a little bit there. And then I could localize through there. Don't let me push you down. And then that brings a lot into my fingers there, actually, and let it go. If that didn't do anything, I could check. If I pull up, that doesn't bring anything in, but man, I tell you what, that brings a lot in. So those are options. I could also check lower trunk rotation, one side versus the other. That doesn't do much there at the occiput. That does right there, does a little bit, but I would probably, maybe have her do that back and forth with their knees a little while, and then maybe combine it with some of the other chin tuck cover position. So that's medial to lateral. If I want to look lateral to medial, I would start at about C2, spring test towards the spine, C1, spring test, and then work along the occiput here. And you may have to be a little bit higher up the occiput than you think that you would need to be, because there is a lot of restriction that could be a bit higher up. So I could be there. And then I would go through kind of similar functional mobilization options, nodding the chin, breathing, cover position, lower trunk rotation. All are great. Combining them could be even better. But again, you want to maintain the infill. So that's how we work on soft tissues, suboccipital soft tissues on anyone that has neck pain, headaches, anything like that.